Okay, I'm going to steal Jeff Brady's idea. Anyone who cared enough about safe and effective use of AI to show up here today, you have to stand up. Yay. Okay. Feel free to stretch. Awesome. So Ken and I were born the same year, I believe, and have been chasing each other around all these conferences all these years, and I'm a huge admirer. So it's tough to go after him. Okay, so I'm from Ohio State, and what I'm going to talk about is the first half of the talk, I'm going to tell you what work system resilience is, and the second half of the talk, I'm going to tell you 7 opportunities to do research on work system resilience with AI. And so, you know, theoretically, a DARPA program could be started, an ARC program could be started. So I'm trying to, but I also think, honestly, that you guys should stay in the room because I'm hoping that industry also will find it valuable. And so it's not necessarily a research thing. It could also be, you know, some kind of industry partnership thing. So let's go ahead and go. I need to figure out how to use this. Okay. I'll just stand here. I'm not as good as Ken at walking around. So feel free to email me for my slides if you want. You can take pictures too, whatever. I'm happy to share everything. So when we think about AI, the first 4 are all the standard ones that we use for any technology, you know, electronic health records or health IT of any kind. It's sort of the standard, you know, they won't use it, they will use it weird. They'll scan the wristband on their belt instead of the wristband on the patient. They'll trust it when they shouldn't. It'll add to my workload, it'll make my workflow worse. But not that many people think about the last one, interfering with existing sources of system resilience. And so I'm going to argue that most of the sources of system resilience come from people who know how to adapt and who listen to each other and work with each other. So there is an incredibly expensive Navy ship that has never left the dock because teams that used to be able to listen to each other from their workstations were put in separate parts of the ship. And they didn't know that they kind of listened to each other. They thought they were independent. And so they literally can't steer the ship off the dock. And so there are analogies when we think about AI embedding where we forget that there's more than one person. We forget that there's people who are working together that we might not know they're working together. You do not need to know what human factors is. Everyone's told you, so we'll skip that one. All right. When people hear resilience, the first thing they say is, so what you mean is we need to have a mindful moment? No. Mindfulness training has 0 impact on work system resilience. Work system resilience is not about PTSD, it's not about trauma, it's not about anything like that, it's not about being a resilient person who overcomes things. Work system resilience is, and I like to think a lot about the emergency medicine, shout out to my friend Mary Patterson who's helped with these ideas in the ED. She flew me out 3 times in the last year to talk through them. So it's, if you think about an ED, right? What do you do when you run out of chairs? we know you're going to run out of rooms. We know you're going to have chairs that are acting as rooms. What do you do when you run out of chairs? So how do you adaptively adapt your functioning? And you also need to avoid going what's called on divergence in the ED, where you don't take any more patients in. So how do we keep operations going? So that's what is meant by work system resilience. So I was fortunate to receive funding from the MITRE Foundation. Kelly Neville is a PhD with aviation and military primarily background. And she had a large team in MITRE. We worked together for years to come up with this little figure. So it's what is work system resilience? How does it relate to sort of IT development? And this framework is actually sort of like I represented healthcare and she represented all the aviation command and control type domains, so it's meant to apply across all of them. And so a lot of people have talked about like best practice alerts, clinical decision support. We are not talking about that in our shared demand and deviation awareness. What we're talking about is after a doctor gets that, alert, does everyone else who needs to know it? And so we think about, there's a hurricane, so you have to change your flight planning. Does everyone who needs to know that there's a hurricane? So it's not just individual alerts going to one person, but it could be like auditory channels that you're talking on that people are listening to. It could be that you push the alerts to a team. It could be that people tell each other important things in a room and you train them how to do that. But it's about the shared understanding of what has changed. The guided local control is, I've literally had physicians in particular stand up and clap because it's about taking power back. So you don't want to have procedures over control you. You don't want to have policies and procedures that are rigid, that are written particularly by administrators who haven't worked the front lines for a while. And you don't want to have the Wild West. You don't want to let people do anything they want. So you need to have loose guidance on what we do in situations. So policies and procedures are resources for action. They are not strong constraints on behavior. So that's sort of the guided local control, that we're guiding people on the front lines being able to have local control over their work. Response coordination makes sense, right? Like we all have to work together and respond. The progressive responding is basically saying you have a plan. So let's say you're going to treat a patient, and then all of a sudden they're not breathing. All of a sudden their heart stops. There's that kind of thing. But there's also, I actually don't know what's going on with this patient, so I'm going to rule out the 5 things, or maybe 3 things, that are the most concerning, and then I'm going to start chasing after, what's actually going on with you. So as you learn things, and while that's happening, you might do what we call safing behaviors. You might just give a patient an IV just to make them feel better, and it might address a lot of issues. So you're sort of, as you're going, you're getting more information, and it's not like, you have the 12 symptoms and you find the diagnosis. You sort of learn things over time and progressively respond over time as a team, basically. Maneuver capacity acknowledges that work's a lot easier if you can recruit resources. So if there's a pharmacist who maybe doesn't know a lot about chemotherapy and they call the PharmD chemotherapy expert on their day off, that's an example of increasing your maneuver capacity. You're recruiting a resource who's not allocated to you in some way. And then you can also think about having just redundancy, which everyone wants to eliminate with the Six Sigma Lean. And I like Six Sigma Lean, I've taught it. But if you just reduce all of the diversity, then you don't have a backup way to communicate if your primary communication mode goes down. And so we think through all the, more than one thing we need through all the areas. So feel free during this talk to go to the website at the bottom there. It has a lot, all of it free. Feel free to use it. So we actually have 3 tiers. I went through the 5 top big factors. We call them the BFFs because we like that. There is hundreds. We have all the way down to the tier 3 level, hundreds of requirements for IT to support work system resilience. So it's written in requirements language, the same language that it's meant to be a copy and paste into a requirements document for software. And so all the way down to the lowest level, it says your software product should blah, blah, blah. And the idea is not only do you create requirements for software, but you protect some of them. So the ones that you've identified as critical to address and mitigate risks with your AI, maybe there's 10 of them, you don't allow them to be traded away during the development process. Because the quickest ones on the table are anything that adds redundancy, anything that adds safety, they will get rid of it. It's pretty much the same reason why my son's high school will always have fluorescent lights. No matter how many times in the initial description of the new high school, they'll have nice lighting. And then they'll go to fluorescent lighting. So that's the idea behind this. And specifically, there's a 12-question critical risks survey that we encourage AI companies to use at the very beginning of the development process to see whether or not to even use AI. And if you can't address them, we would claim you shouldn't even use them. And believe it or not, some of the AI people who are doing like planes in the sky that automatically talk to Navy subs, that automatically shoot drones, they're the people who helped us develop these risks, because a lot of the people developing these technologies themselves don't think they should be developed. And oh, yeah. Hi, my friend from Next Century. She knows exactly what I'm talking about. So anyway, that's this MITRE framework. But now I'm going to say, okay, what's just a couple examples to give you a feel for these requirements. I have 2 examples. So in the shared demand and deviation awareness, one of our requirements is agents are informed and inform others about new and developing demands. So this is a picture that I have borrowed from the late and great Bob Weir's. Anyone notice anything about this picture? So in A, you see that there's a manual whiteboard in the ED, there's handwritten stuff. And B is the electronic whiteboard that's meant to replace the not supposed to exist anymore manual whiteboard. Anyone notice anything about this picture? They're all looking at A. And actually, the person who's looking at B is on the phone, and they're not looking at it. They're just trying not to look, they're just trying to not be distracted by the people looking at A. So literally no one in the room is looking at B, right? One of the reasons why is because the patient overflow, which is one of the key things that you need to know in the ED, how many people are out there, you had to click to the second screen to get to. And no one really feels like it's their screen, and how do you get to the second screen? And I'm sure I'm missing details about all of this, but fundamentally the idea here is if you can't see an emerging increase of patients and how many are building up, it's not going to help you be resilient in adapting your functioning to address it. So for example, Mary has taught me that in the ED you can call people in who will only do certain things as physicians. They won't even visit patients, so they'll just like help to get through, all the paperwork. So there are surges that you can do with staffing if you know that the patient flow is high. Here's another one. So I worked on barcode medication administration in the VA. I was 26 years old. I had my PhD. I'd never worked in healthcare. And they're like, Congress is making the VA put barcode medication administration in. That's your project. And it was wonderful. It was a wonderful experience. And one of the things we learned with version 1.0 is that physicians didn't have access to the software. And that makes sense, right? Like, you're a nurse, you scan wristbands, you scan medications, you give medications. Why would you give physicians access to a medication scanning software? Well, they ended up giving it because what they sort of didn't know, and this is all part of like not knowing what people are doing already, is physicians would go to the paper MAR outside the medication administration record, outside the room, and they would look to see if a medication was late, if there was a fever. Could it be that they hadn't got their medication yet, or is the medication missing? And so they had access to that paper medication administration record to try and look and explain what was happening with the patient. And in a focus group, basically the resident physicians estimated they did it about 7 times a week before BCMA, and once a month they would ask a nurse to show them something after BCMA. And then when they gave them access to the record, I think they did it in between those two. So not as often as on paper because it was so easy, but they actually would look sometimes. Okay, so that's the end of learning about work system resilience. Now let's talk about, the way Dr. Bruno got the grant was he said we're going to find knowledge gaps. So here are my 7. Knowledge gaps. And so what this means is like maybe we could have, a research project oriented around each of these. Okay, so all of these are from a resilience perspective. Every single one of these things has happened. Every single one of these things. So in different electronic health records across the US, there have been configuration setting mistakes, if you will, such as a pediatric hospital, the power goes out, they restart it, 4 days later they figure out that the adult dose ranges had been in place for 4 days. These are things, to me, that seem pretty similar to the successes in ChatGPT for coding. So we're having ChatGPT help with coding. Can we have ChatGPT help with identifying best practices for configurations and making sure that all of those details that it's frankly really hard to do have been done? Does the HR system correctly have the person who started as a medical student who's now an attending physician labeled as an attending physician so that they have privileges to order medications on Go Live? And so I think there's a lot of opportunity here, and I am working on a project with the VA right now. In the next 12 weeks, I'm going to be looking at 3 sites that have implemented Cerner, and then I'm going to be saying for the next 140 sites that are going to be implemented in the next year-ish, how can we improve the medication reconciliation, inpatient and outpatient configuration settings for all the workloads for all of the specialties? So pretty much the same thing, right? We can try and use technologies that can look to see what the configurations are and compare them against each other, whether or not it's ChatGPT. We talked about how ChatGPT is not ChatGPT. But basically, taking that text in and comparing. Okay, so this is Stephanie Gerlain's dissertation research. She looked at antibody identification in blood banking. And so when we think about a resilience perspective to AI, one of the missed opportunities in my mind is having, and actually Ken mentioned this in his, what does AI do? Critiquing is a form, I think, of being an advisor, I would say. And so how can we have the human do work, so not replacing the human, but the AI is like tracking and telling you what you're doing wrong. And so that's how the system was designed. It's antibody identification, specifically looking at like after an organ transplant, if you have an antibody, allo antibody from that. And so for example, you could incorrectly say there's 1 antibody in the blood when there's actually 2. Because 1 could explain what you're seeing, but there's actually 2. And it matters because you don't want to have antibodies that don't match the donor that you're giving the blood to. And so she set up 4 cases. 1 case was like a weak antibody that's wrong, 2 antibodies are 1. So she set up these cases and she had the critiquer help. And the bottom line here is having the antibody identification support underneath a system that supported the person doing the work, reduced diagnostic errors, I think for 3 of them all the way to 0. So we can reduce diagnostic errors by having AI critique people. What I have not heard as much discussed at this conference yet is how AI can critique planning. So when we have treatment planning, when we have, we're going to do this for the patient, there's opportunities there as well. So this is Phil Smith, who actually was Stephanie Gerlain's PhD advisor. He was on my PhD committee. He had a student work on a flight planner. And he had all these different configurations of, did the flight planner give the solution to people before they worked it through? Did they have to work it through themselves and then they got the solution? Did they not have no support? And I wish I could say the critiquer improved planning performance. But actually what he found is that for the brittle cases where it's wrong, even when people personally did the flight plan about the weather patterns and how to have the best route and the shortest route and have the least fuel, even when they came up with a good answer themselves, working through the problem just like normal work, and then the system showed its automated response, they would change it. And so this is kind of more of a warning. And they sort of said, well, we have thoughts about how maybe it could work in the future. And then that didn't get followed up. So I think there's a whole lot of opportunity, but it's as much a warning to us that even if we ask people to do the work themselves and then they get the automated solution, they will, based on these studies, they will often change their mind. Okay, this is ARC-funded work, so thank you. Susan Moffett-Bruce was the PI. It was a patient safety learning lab. So what you're looking at is across 3 hospitals, we implemented, and I'm actually going to play it and then go back. Hopefully I can go back.
Code blue.
Sorry. You'll hear it again when I go to the next slide. So before we implemented that, it was like the ringtone. So we had these, it's a secondary alarm notification system. It had like a generic ringtone for all of the alarms. And so that was the code blue alarm. So the ones that were the highest positive predictive value because people had initiated them, which is almost always the highest positive predictive value, the fewest false alarms. We used voice for code blue and some others that were emergency ones. And the second we implemented it, you see that line, response times to the alarm went down. And it was sustained over 2 years with essentially no change, which is unusual for most interventions, kind of because it was hardwired into the system. And so before we started, some of the hospitals had more than 2 minutes for response to code blue. So not only was it, a 15 to 59% reduction in time, it was also clinically significant. And at the same time, we reduced the number of alarms significantly. So up to 39% reduction in alarms. For example, we combined bradycardia and low heart rate alarms, so we got rid of the bradycardia alarms. And in our focus group with the nurses, they accused us of increasing the alarms. I think it's because they could hear them. And so they considered them annoying because they could hear them now. I think they were literally not hearing them before, or some of them. Well, how does this have to do with anything with AI? Sorry, I will move on. At least I woke you up. So something that is being shown here is, to me, I really wish that we could have done more with this. Funding ran out. The Navy funded some of this as well, luckily. What you're seeing is a unit, and each line is a hospital bed where there's a telemetry alarm patient. And then the alarms are color-coded. And so I've highlighted here the blue alarms are the SpO2 low, which everybody knows is like the really bad alarm in hospitals. It's the pulse ox that falls off your finger and you have low pulse ox. It's 37 to 69% of alarms. And I can't remember the overall alarm burden, but we're talking thousands in hospitals. We had up to 12 simultaneous alarms on the units. And so here's an opportunity where we can use AI detection to say, look, there's a lot of alarms on one patient, and maybe only send 1 instead of 100 on that patient in an hour, that kind of thing. And so this is low-hanging fruit. I was so close to being able to be implemented. We worked with Siemens a little bit. We talked to Connexall a little bit. It was so close. And as far as I know, nobody in the country has done this yet, I don't think. Let me know if they have, because SpO2 alarms, huge opportunity. Then there's non-actionable alarms. So this is where it's true. The patient has a low heart rate alarm. So these are the low heart rate colors. Same thing, beds on a unit with telemetry. So yeah, it's true, but do you have to tell me 150 times in 2 hours that this patient has a low heart rate? So this is like really easy, right? After you've had like 3 in 2 minutes, maybe you could turn the thing off, right? So again, I don't know why it hasn't been implemented yet. Totally ripe for some kind of AI suppression. And then there's ones that are less of a burden, but pretty easy. So leads fail is when you take off the alarms because you're having a bath. So it's going to say leads fail because the leads are off. So that's an artifact. It's not actually informative if you know the reason for why it's happening. Similarly, no telemetry, same kind of thing. So if you know somebody's jostling it, there are times where you know not to need it. Okay, 5, almost done. All right, So improving care transitions. This one's a little bit harder to explain. So how many of you have heard of A-bridge or nuanced stacks? Okay, a few. So ambient communication technology has taken off in primary care across the United States. Sometimes it's through hospital-provided devices. Often it's through physician individual cell phones that allow and give subscriptions to the physicians to have them on their phones. And so imagine in primary care, you go into the room with the patient, you put the phone on the desk and you say, I'm going to record this. It helps me make sure I remember everything that you said and everything that I wanted to do. And then the ambient communication is tied to a ChatGPT prompt that then creates a draft note for you. Some of these systems go so far as to pen orders for you for the patient in the electronic health record. And so how is this potentially valuable for a care transition? So in the ED, patients are not really supposed to be there longer than a shift, but they are. You have patients up to 36 hours in the ED. So you have a resident probably goes and assesses the patient, does all the workup, figures out where the patient should go, does a disposition decision-making, and then the patient sits. What happens is that handoff or sign-out is pretty good from the physician who assessed that patient to the next one. The one after that, not so good. Because that second sign-out, that resident has never even talked to that patient potentially. And so they'll say things like, been here 6 hours, upper GI, don't know anything else. And so Mary and I have been working on this. This is the top safety issue that has been identified by both the residents and faculty, is a decompensating patient where you're like, I have no idea what's going on with this patient, and now I'm supposed to intervene and help them. And so Mary and I had talked about, we might be helping sign-outs or handovers in the ED, and they're like, oh, if you have to. Because they thought we were going to give them an acronym or something where they have to change their things. And then we said, no, like a Post-it note, it could have, an automated summary that's generated from listening to the first sign-out there. And they're like, oh, do that right now. So, it's sort of important exactly what it is we do. But the idea is when you have an important communication event that has a whole lot of knowledge, how can we capture that and summarize that? Because yes, it's in the chart theoretically, but being in the chart doesn't mean you can access it. You have to forage through the chart. It's got a lot of templated stuff. There's a lot of things for billing, and so it's not clinically oriented. And I think a really key part of this is making sure it does not go in the chart if we can avoid it, because it's meant for clinical care now, today, not for all the things that happen later with the chart. The other opportunity we identified is, say you're a surgeon and you receive an ED consult that says, please do an imaging order. Are you going to act on it if there's no other information on that patient? Probably not. And so, yeah, we can improve turnaround times for radiologists reading images, but how do we improve the delays before the imaging order is written? A really obvious opportunity is to have this ambient communication turn into a summary that is provided along with that initial request for an imaging consult. And at least the people we've talked to, we haven't really heard any issues. I'm sure we will, but as of right now, I think every single hospital in the country should be doing this right now. I can't imagine a reason not to. Particularly if we start talking to people and say, how do you want it to be formatted? How do you want it to look? What are you worried about? So I think we could use it there. All right, another one is, I think Aisha was working on AI alignment. Is anyone else working on AI alignment type stuff? Okay, so AI alignment, supposedly robots will be killing our babies so that we don't hear crying as parents. So there's concerns at the very top level about humanity being destroyed because human values are not going to be aligned in very, very capable AI systems. Let's take it back a little bit from that. And let's think a little bit about alignment of values So we already have research that I and others have done, which basically says, and I did it in a nursing context, there are some things that are always highest priority, and there are some things that are always lowest priority, and then there's some stuff in the middle. And so we really don't want, if a patient is going to die in the next 5 minutes if they don't get a certain medication, we don't want one of these pick or vending machine type systems saying your password doesn't work. So we don't want security to trump production of, giving health care to somebody who needs it urgently. And I think potentially, as we think more 5 to 7 years out on what we can do, I'd love to see context-based goal prioritization. So we talk in aviation about, a pilot, and again, there's actually pilots in the room, so I apologize to you. I'm not a pilot. But my understanding is in the military, there's a rock the wings thing, where sometimes pilots will rock the wings, and that's a signal that's indicating, we're going to change to another mode, we're going to regroup and change how we're flying. So what's like the rock the wings analogy in healthcare? Have we just entered a surge period in the ED? Do we have COVID patients? Are we worried that there's somebody, who came in with a gun who might shoot people? What are the context-based situations where we need to shift everything in our IT system to have a different priority right now? And you can even imagine having optimization packages like Arobi or something like that, where it has an objective and it has assumptions. And when you shift the top level goal, you shift your planning and your scheduling and what you're doing. And so now we're going to be scheduling, patients from the military who have, just been gassed or something. They're all going to go first today into surgery. And so it would be nice to have some kind of interactive platforms where we can shift the goals, shift the objectives, real-time optimize, reschedule, replan, based on things that the AI helps us to recognize has happened. So this is one of my more out there ideas, but hopefully you can help me to fill in like what we're talking about on that. And then this is just like the obvious case. So this is already published. I have a 7-week class on clinical use of AI. 1 week I say, don't use ChatGPT to primarily diagnose, but you can do alternative diagnoses. And week 2, I say, use ChatGPT to do text conversion. So this is an example of text conversion in a paper I found. It's already out of date. It's already an old ChatGPT. But what is at the top is the prompt that was put in to ChatGPT. Then the input was the description of what was in the image. And then it at the bottom is what was created. And so already, even a couple years ago, we had technologies where you could text convert. And so in my class, I have an example of an elderly man who's Chinese, doesn't speak English, who's been using herbal medications, who has acute on chronic kidney failure. And I'm like, what do you think about making a Chinese version of this? And so, yes, we can make 8th grade or 4th grade or whatever level we want health literacy already, but can we do a patient-centered one? And my understanding is right now these kinds of technologies actually do really poorly at the high levels of intelligence because social media doesn't tend to be there. So if you want to give like a high PhD level understanding, it actually doesn't do very well at converting. And there's probably some languages that it doesn't do very well because it probably doesn't know the languages very well. So all these things could be improved by training. But let's think through who are our patient populations, who are we trying to reach, how can we convert to them, how can we create our LLMs to have the data that will allow us to meet the patient groups that we're trying to meet. And then let's have prompts already created that eventually turn into buttons, that eventually turn into features that say, I have a 49-year-old Chinese person who doesn't speak English very well, give me the summary for that person. So I think that would be an interesting area to take all this. Last slide. I left time for questions. All right. So to have resilient AI, so now I'm just literally stepping back and saying what's in that trust framework. So I gave you 7 specific ideas, but now I just want to say like the general rules of the road for having resilient AI. One is that we don't want to be overly structured, but we also don't want to have over adaptation. So we want to have some structure, some loose structure, but emphasize the ability to change things and adapt things within that structure. We want to make sure that we identify where we think the AI is going to be wrong and think really hard about warning flags. And so I envision ChatGPT outputs that have yellow and red text on things where it totally just made it up. It can't do that right now with the current technologies because it doesn't know. But one of the opportunities we have is you can actually have LLMs that have better vetted sources. You can already now, out in the current marketplace, have that critique the output of an LLM that has had all the stuff put into it. So you can actually start having LLMs critique LLM outputs. I'm also thinking we can start having, that dose looks like it's too high, or once we understand the medical terminology and the dose ranges and things, we can have the equivalent of dose range checking. And, I'm not really feeling good about this part of the suggestion created by the LLM. By the way, I don't know why I'm sharing this, but I find it interesting. One of the mistakes that a particular technology made that was this ambient communication stuff is a patient came in with their nurse, and the draft note said the patient's spouse, who is a nurse, said. But it wasn't a spouse. So one of the things that we can train these things on is the social relationship specific to medicine, because it makes the assumption that anyone coming with the patient is a spouse. That's probably something we want to make sure that people tell us who's in the room. And so you can have, even just with training, you can say, before we start the ambient conversation, who are you in the room, what's your name, and what's your role? And actually the ambient communication does better. It says who each person is, and it does a better job organizing the transcript if you do a who's in the room and who are you and what are you going to, what's your role to this patient. Facilitating sources of resilience, that was the whole talk. I won't read them to you. That's the big 5. And so thank you so much for your attention. It's been fun to share all this with you. Here's my email. Send me things, ask me things. It's great.